Our interviewees today are Doctors Joe and Mary Muscato. Doctors Muscato are in joint practice, or have been in joint practice of hematology and oncology in the community around Columbia, Missouri. We've interviewed men and we've interviewed women, but we've only interviewed one couple in practice together. So I thought it would be interesting to hear what you have to tell us about working together.
Yeah.
What are you currently doing? Are you retired now, or where do things stand?
Yeah, we're retired. We've been retired about 2 years, and we enjoy that a lot. We do volunteer. We teach over at the university. We teach PBL to second year,
So much fun.
mostly second year medical students, problem-based learning. Mary gives lectures, has always given anemia lectures, and we travel and we just enjoy ourselves. So that's, and I'm president, as you probably know, of Missouri Oncology Society. So I still deal with those kinds of issues that we have to deal with in terms of the state society.
So tell me, when you were in practice, what was your practice model like? What did you guys do, and how did you do it?
Well, it was a practice that I founded. It was I'm probably one of the last people that actually went to a bank and wrote a business plan and borrowed money and started a practice. I don't know how many people do that anymore, probably zero, I suspect, unless you're like a dermatologist. And so that was how it started, but it grew from, me to ultimately peak of 9 oncologists, radiation oncologists, and urologists. So it got to be pretty good size. And we were in academics. We came actually initially to Missouri to join the faculty at the university, and that's probably an issue in its own right, because we had come fresh out of fellowship at Duke, and we were not, I don't think, treated very well in the academic part. Mary and I and Rich Shilsky, who ultimately also left, and I don't know if you know Rich, but Rich became ultimately head of the Cancer Center at the University of Chicago and president of ASCO. So obviously not a slouch. We knew him for a long time.
Yeah, and the head of CALGB.
The head of CLGB. So he was obviously a good thing. And they let him sort of fester and leave because they didn't treat him well either.
No, and he was my organic chemistry partner.
Yeah. So it was a kind of a problem. I mean, and every academic environment is different, but I remember when I was a brand new faculty member, and I was coming out of a meeting. It was just a hematology meeting with students and faculty and stuff, residents. And one of the third year students, sort of following me in the hallway, said to me, "Dr. Muscato," he said, why do they treat you like that?" Which was kind of an interesting observation.
What did the student mean?
What he meant is
meaning everything we said.
It was like. It was an interesting problem because there was a faculty member there who we remember came from the Mayo Clinic.
Smart
we
guy.
were interns, very smart guy, and immediately demanded sort of the prestige of saying, "I'm the smartest guy here," like I'm the god. So fast forward 6 years, we're brand new from the same quality training program as he came from. And it was like, no, I know everything, you don't know anything, so like that contrast was kind of there. And,
always,
you got to say something and they would just put you down. I mean, in terms of like, no, that idea isn't that good, that kind of stuff. And,
like at the end of grand rounds one day, I had asked permission to have 5 minutes to bring up the idea of ordering ferritins for iron deficiency.
Fairly new at that time,
yeah. Instead of FUTIBC only. And I had slides from the New England Journal article that had just come out about this. And, and all I get from the back of the room from him is, I can look at the smear and tell you what it is. And I'm thinking, I'm talking about the
This was in front of a grand rounds. This was a comment to her in front of a grand rounds. To one of his new faculty members, right? Is that an appropriate way to treat somebody? So anyway.
So was this sexism, or was it just
not really? Well, a little bit of that.
It was both.
His initials happened to be MCP, but that was sort of between there. And
He had a tie with his initials on it and pigs.
But anyway, so what happened with me was I happened to get some of the surgeons in town had come to me and said, you know, we really would like another oncologist in town. The one they had at that time wasn't very good. And I said, oh, yeah, maybe I'll be interested. I'll talk to you. And, you know, that's when it sort of interestingly came to, you know, developing a business plan and trying to start a practice. It was interesting. I had to go to 3 banks. The first 2 banks turned me down, and there was no need. No, 3. There was no need for another oncologist in town because this well-connected political guy had got everything wrapped up, and
So 50
there was a
people
lie to
today
that
and
because
examined none of them.
yeah, there was a lie to that because when I went into practice, I was so busy thought I wasn't going to make it through the first year by myself. I was on call 24/7. You know.
Let me ask you, Mary, did you stay at the university at first when Joe went into practice, or did you go together?
No, I didn't leave then because one, I loved teaching, and he was working 100 hours a week. And we had a son who was born 6 months before we started. I started in September 81. He had started in August, I think. And then I stayed through after our twins were born, which was 31 months after the first one. And he was still there. He then had one partner, but you know, if the twins hadn't, you know, taken up time on top of the 3-year-old, and if life hadn't been insane, and we had a wonderful daytime nanny, but I didn't want to be gone 24 hours a day. But it just became impossible to do. Like they put me as attending on the new idea of a heme-onc ward, which makes perfect sense, except that there were 3 acute Lukes. There were all these people on protocol. There was no fellow. I was the only heme-onc person. And I had to be involved with all the decisions, of course. And it was just so much, you know, and the kids were waking up at midnight, throwing up on the rug because I didn't pick them up instantly. And I said, you know, I love doing this. I love teaching. I love the whole thing and the patients, but I just can't do this. And they said, well, you could have 6 weeks that are intense like this, and then 6 weeks in the clinic. I said, well, that's a start, but I can't live through 6 weeks of this again.
Children don't exactly go on that schedule.
No, so I went into practice part-time, very specifically part-time with them.
Which is another issue for the practice issue, because at that time there were only 2 of us. I mean, later I said we grew a lot, but we took Mary on as an employee physician, not a partner. And if you're talking about practices, and we are going to talk about that, you know, there are a variety of practice models in terms of how they're structured, who runs the practice. Payment may be related to that. Buy-ins may be related to that, although those don't exist really anymore. And so Mary was employed in that structure because she wanted to work less than full time, and she wanted the ability to structure her time the way she wanted to.
Yeah.
And I was, of course, happy to do that. So that was in a unique kind of situation. We actually ended up with another couple who came from Duke. They called us and they were just asking questions about married couples. And we said, are you looking for a job? Because we knew them from Duke. They said, yes. So we offered them a job. We did the same thing. He came on as a partner. She came on as an employee. Those kinds of structures were very unusual at the time, and may still be unusual. But it allowed us for them to sort of say, this is what we wanted to do. The kids are involved in both cases. And, you know, they didn't have to take as much call. I mean, it was like, it was a different side of structure, but on the other hand, they didn't get paid as much, you know, so it was a trade-off there. And this quality of life issue with this balance and how you do structures is important. And I know there was a question there about structure of practice, so we might as well talk about it, I guess, because that's sort of.
Well, I have one follow-up question to what you just said. I can easily imagine a young woman today bristling at the idea of being offered a salary position as opposed to a partnership track position. Was that ever an issue for you guys?
A little, but there didn't seem to be any way out of it. It's like if I wanted to work with them and work part-time, that's what I got. Take it or leave it, kind of.
I mean, no, you know, if a woman came and wanted to do everything, call all the responsibilities, the management responsibilities, that wouldn't, hold us up. It wasn't the fact that it was a woman. I mean, it was the fact of it was the issue about what that woman wanted to do with her life as opposed to what we wanted. You know, does that make sense? You know, because
And then a technical question, by that point, now that you had several employees, as you were getting bigger, were you requiring a buy-in for partnership of your new partners?
that changed over time. There was a buy-in originally in the practice. Don't forget, we ran our own practice, and so we had infrastructure costs and so on. However, we felt after about 12, 13 years, there were practice management companies that were sort of coming on board that were looking at purchasing assets of practices. And so, and this became somewhat of a sore point because what happened is US Oncology, became US Oncology, now it's part of McKesson, but at the time was separate, were managing oncology practices. They would buy all the assets of the practice and then they would manage the practice, and there would be a contract with them to manage the practice and so on. And so when we did that, we sold all the assets to them for a fair amount of money. Those kinds of things don't exist anymore. Okay. I mean, seriously, we had built this practice up to where the partners were, when the buyout occurred, and I hate to sort of say this because I know people will think this is just awful, but they paid us in excess of $1 million each for the assets of the practice.
And zero to me and the other.
Because she wasn't a partner, and that became in Mary and the other woman too, Pam. So yeah, that became a sore point.
And I said to them, could we have 20,000 each, maybe just as a show of goodwill, because you're getting another $1 million because of the two of us.
And one of the partners said no.
I turned bright red.
Yeah,
and
it was a problem. Those are the realities, unfortunately, of issues.
Sure, I think it's important for people to hear this. Not, would you do it the same way again?
No. In fact, the practice over the course of years, I know the partners. I didn't necessarily get involved, but they sort of said at this point they're not going to do that again. I mean, they kept Mary and Pam on as employees and part-time and at their wishes all through their careers. Mm-hmm. But they said they weren't going to do that again. You know what I'm saying? But the structure's changed too. There's no buy-in anymore. There's no payout. I mean, it's like that all went away when the practice management company, and it would be equivalent to a hospital buying a practice. I mean, it's somebody's running your practice. There's a lot more control. We had a lot more control over the practice though than typical hospital-based physicians does. There's a big difference there, absolutely, and I'll get into that if you want. But the issue there is that at that point we had no assets. The physicians didn't. We ran the clinical part, but since there were no assets, there was no buy-in, there was no buyout. Actually, we did have a buy-in, a buyout. We had a dinner. You had to pay for dinner.
I do want to mention
that was the deal.
There's a woman who's in the practice now who has 2 kids who were probably junior high age and has been there for about 4 years. And her husband works with, I think he has some real estate stuff, so he can do that, but he doesn't have like a 9-to-5 full-time job.
She's a full-time. She's a regular full-time.
Yeah, totally. And that
so Mary, did you remain part-time for the duration of your career, or did you go full-time at some point?
No, sometimes they needed people to take call because somebody was gone for a while, so we would do that. But overall, no, to have both of us working 60 or 70 hours a week, it just didn't seem worth it. I mean, and he did more of my hospital stuff, than if I had been totally full-time. But, and not that, I felt guilty about that, but it just to keep everything running and different things with the kids, it's not like I went and played golf 4 days a week at all. It was just to keep everything afloat. It'd just be hard to have 2 people each working 60 to 80 hours a week.
I think one of the issues that if you're looking at, as a resident, looking at this kind of thing, there are different practice models. And basically, you can go into a private practice, which can be self-contained, could be multi-specialty, single specialty, whatever. You can go into a hospital-based practice, of course. And I think those are probably the two biggest, an academic practice, of course. But the private practices there are a multitude of structures. Many of them are managed either by, if they're very big groups, they can be managed by themselves. Everybody hires managers. I mean, you've got to have somebody to run this sort of. In our particular model, and I think when you start talking about quality of life, or at least in terms of practice quality, not talking about taking care of patients, but I think control is a huge issue. It's the old story of I don't get ulcers, I give them, sort of thing, and the question is, where is the control? And in our practice, even when we hired the management company, we hired the management company, right? I mean, they took a big chunk and they, that was a contract and all this kind of stuff, and they made their money and we made ours. But the way it was structured is we had a management committee, which was 50-50. So like they couldn't just come in and say something and do something without our approval. They respected the physicians as the people who were in charge of the practice, at least in terms of clinical practice. And by law, they couldn't practice medicine. So we actually, in a sense, all the clinical employees worked for the physicians. So like, if a nurse wasn't working out, we could get rid of the nurse. If we had to change things around, we could. If we had control over how patients were obviously taken care of and so on. And they went along with that because that was the deal. So I think that's a big issue of control. And I think one of the things that you have to look at is, who hires your nurse? Who makes those kinds of decisions? How do you work in terms of quality? How do you get scribes? How do you make those decisions? And who's going to make those decisions? And I really think that the big advantage of a private practice is where the control lies, and I think that unhappiness occurs a lot when somebody else is in control and you don't have anything to say about it. Now, there's a trade-off. I mean, if somebody's taking care of all your problems, then you could say, well, that's a good trade-off. I don't have to worry about anything. I just walk in, I get my paycheck, and I walk out. And boom.
That'd be interesting. There's been this trend in recent years, which you alluded to, of venture capitalists and large companies coming in and buying up physician assets and physician practices and turning them something much larger, like Quest and Pathology and US Oncology and DaVita and Fresenius and dialysis and so on. Do you have any thoughts about that and the relationship to young physicians coming into practice and whether they should or shouldn't avoid those kinds of things?
I don't think you can avoid them, really. I mean, I think that, it's just be careful who you get in bed with. I mean, it's like the question is going to be, what kind of company is it? I think you have to understand when you go in, what's the respect for the physicians? What's the control of the physicians over the physicians? What's the management philosophy? I mean, hospital-based physicians are the same problem. It's not that you're going to get better or worse. I think in most of the situations where physicians can make their own deal with the company and walk in with their eyes open, it's probably going to be better than a lot of places where you walk in and this is the hospital, this is the deal, and take it or leave it. You don't have any control.
But the company would have to have the patient's needs first. I mean, that has to be at the top. You can't have we're cutting this and this and this to do this. Absolutely not. And I think that has to be understood, or we got to run away from it.
Yeah, so that is an issue. And I think the problem is you have to understand the history of it. And you can't control a lot of times a company that gets bought out later on, so you're kind of stuck. Although, you have a termination of the contract too. And how's that dealt with? Hospitals are going through the same things. Sure. Practices are going through the same things. I think the other practice model for internists, which I found to be, I'm a subspecialist, so it doesn't work for me, but are the concierge practices, which is like the other side of the coin, to me. I mean, I think, although they're all run by, a lot of them are run at least in groups like MD, VIP or something, but the practice where say, okay, just pay me a fee and I'll take care of you, you know, and
matter
some
what.
people bill insurance, some people don't bill insurance, but there's the other side of the total freedom issue. You know, it's like, I'm getting out of this and just do that. I think those can be very, I mean, I think they can be attractive, you know, practices too for a physician. You know, so I think when you go into practice, you're going to have to say, you know, what kind of lifestyle, what kind of control of the patients do I want to have? You know, and we spent a lot of time, Mary and I, talking about the practice, taking care of the patients, which I think part of the problem is that we're getting away. And I think one of the problems of internal medicine, the tragedy of it, is that we're getting away from what the basics of internal medicine are. You know, because the basics are, how do you care for a patient? And a lot of these structures will take you away from that. I know of a really good internist. He's an ID guy who's at our hospital. That, you know, he, in a sense, did himself in because he would spend so much time with one consult, going into extreme depth. And you know, ID people.
You have to do that. And
I think he ended up leaving the hospital. I think they sort of asked him to leave because it was like he was not productive because he was taking care of his patients. So I think one of the issues that you've got to ask yourself in going into any practice is, you know, when you talk to the fellow people there, the people who are already there, you know, how do you take care of your patients and how do you get that as a quality of life issue? Because, and one of the things that Mary and I were talking about, if you want to look at the fundamental part of internal medicine, to me, it's ownership of the patient. And my philosophy, and I think the philosophy of internists need to be, that if the patient's in front of you, it's your patient.
yeah.
And I don't care what else is going on. This is now your patient and it's your problem.
And you will either take care of it or get them to somebody who will. You won't just say, oh, I don't do that, bye.
You know, and I think the thing that over the years that I think I've seen lost in medicine is the ownership problem. It's like, it's become not my problem as opposed to, yes, you're my patient, you are my problem, you know, and, or not that way, but I mean, I need to solve your problem. I need to help you with this. And you also miss half the fun. I mean, because like, you know, the fun of what I do is I diagnose all sorts of diseases that are not oncology related, you know, but it's fun. And, you know, you've been to the situation. I go down to the lake meetings, you know, and people say, what are you doing here? And I go like, well, I enjoy this.
Yeah.
I enjoy internal medicine, listen to internal medicine lectures because I'm learning a lot of stuff. And you know, it's stuff that I really use. I mean, it's like, it's not that I don't see hypertension. It's not that I don't see heart disease. It's not that I don't see diabetes. It's not that I don't see this. And you know, do I take care of diabetes? Not really. I mean, I don't want to delve into the depths of diabetes.
The other thing is,
but I got to know something about it. And I got to know something about what's going on with the patient. I'm going to take care of them.
Right. And even if you're not going to do everything for every different thing that the patient has, you still want to be participating a little bit and be in on it. But I mean, the idea that, oh, I don't do that, goodbye. No, I mean, you might be the first one who finds it and then you get them to the right person, but you don't just say, no, I don't do that. I mean, that I don't understand that at all. It's like, it's your patient. You either take care of it or you get them to the best person who can do it, but you don't ignore it and you work it up as much as you can reasonably. I mean, I would not do endoscopies on people. I don't do that. You know, there are way better people who are trained to do that, but you can try to figure out what you think they need and not just ship them off to somebody else and say goodbye. And it's like, it's your patient. You want to make sure that every single loose end gets fixed. And like when we were interns and, you know, and hopefully throughout our practices, you know, if you have somebody with a bunch of problems or even one problem, you would write down that problem and this is when I'm an intern, it was written, you know, then you'd write down all the possible differential diagnoses of each problem and systematically go through it all and check it out and get everything resolved one way or another. You wouldn't just blow it off ever. And you took care of the patient. And somebody who forgot to do a rectal with a hemocult on somebody upon admission when we were interns, he was scared to death because he went to dictate the discharge summary and there was no rectal there. And I was coming on or something, and he asked if I would lie. I said no, but I didn't want him in trouble. But you have to do the right thing. You have to take care of everything. And the guy didn't come in with GI bleeding. He probably came in with headaches or something. But you have to take care of the patient and not just, we'll do this and then come back again later. And now with the idea, not to get you off where you were, Joe, but the idea that, okay, like this is like drop by and then leave in 10 minutes. Like, what's your main problem? Okay, we'll deal with that. And then you can come back another time. No, and not that you have 4 hours for each patient every day, but you have to acknowledge and believe that it's your job to recognize what needs to be worked on and make sure that all of those things are being worked on, not ignored.
Yeah,
And
the reality is, like you say, Mary, is that these patients, and I don't know if it was just our practice, but these patients really looked upon us to help care for them.
Yes.
I hate to say it, but they would call my nurse way more often than they called their primary care doctor.
Exactly.
They knew we'd pay attention to them. And, and of course, when they came back, if they were having some other kind of specialty problem or other kind of problem, they would always ask me, what do you think I should do? I was told to do this, and I have to know something, about that to give advice. And, you get into this thing about what's your quality of life with your patients. And it's like, I remember one guy that came to me, and every time he saw me, I can't remember what he had, renal something, but, he would always, the first thing he would always do was show me photographs of the things that he made, because he was a craftsman and he made all these things. And one time I think somebody said to me, Doc, why are you sort of looking at his pictures? I said, because I said, he wants to show me his pictures. This is really important to him. And I say they're beautiful, so I like to look at them. But it was like, is that part of medicine? I mean, yeah, it's part of taking care of this guy. This guy wants to come in, and one of his big parts of his day is to come in and show me his pictures of the stuff that he made,
And
so
something that I always—
I'm being therapeutic? Sure, I'm being therapeutic. I'm looking at his pictures,
Something I always tell students is, you want to be a doctor like Marcus Welby, who they've never heard of, but I tell them that is the kind of doctor you need to be.
Yeah. So let me question each of you in turn. Mary first. What was your day like, a typical day in practice when you were in practice? You start, Mary.
When the kids were little, the babysitter would come over, and I'd leave to go to work, and I'd see, only 8 or 10 patients a day, which is about all I could do because I talk too much. But I wanted to be like their doctor and their friend and take care of everything and take care of them, and not just, do the one little thing and move on, and I don't know. And so I'd see all these people, some who I'd seen for years and some I still talk to now on, text messaging, and try to figure out the best thing to do for them, and, see if there is a research trial, and look at their blood smears if they had anemia, and, stuff
but
like
most
that.
of the time you early on, you went to the hospital, but you stopped doing that. Right?
I didn't do that much. Yeah. And that I feel guilty about that, because there's a whole segment of it that I wasn't that involved with later on. I mean, I'd come and see him once in a while if there was really bad stuff going on, and I knew I could trust Joe completely, 110%. And he kept me informed, but I feel bad that I didn't do more of that, because that's part of it too.
Yeah.
But otherwise,
is it a sign that you're talking about patients that you've known for years and you're an oncologist?
Oh,
I
yeah.
love that.
Oh,
I love that.
Yeah, I think this is one of the great misconceptions about oncology. I went into oncology because I like patients, and I wanted to feel like a family doctor. And you have some of the closest relationships you ever have with people as oncologists, and
Yes.
you would be surprised how many patients live a long time. It's not like that unusual. You think, people have this misconception about cancer patients. They really are. It's really, I mean, and the students would say this all the time. They would come over and they would say, we expected this to be like a morose place, and it's just not. And they were laughing and we're having a good time. And I said, yeah, these are people. I mean, they're not they're not any more depressed than anybody else is. I mean, yes, they have their cancer, but they still have everything else. And we have a good time. We laugh and we have a good time. It's not at all a morose place. And
I mean, sometimes
many of our patients do very, very well, and we follow them for many, many years. You know,
So Joe, what was a typical day? What was a typical day for you like?
well, mine was different because, you know, I obviously, you know, did the hospital work too. And we're still in this mode in our practice that we take care of our own inpatients, which is, I guess, getting to be another issue, you know, with this. But with subspecialists, especially, I think it's a little harder to rely on hospitalists for your care because the patients are there because they have a specialty problem. And
I mean, like,
so,
wouldn't
and
give
we
them-
toyed with the
would
idea,
not
we
do
toyed
it,
with the
you
idea
know,
of rotating
sometimes.
call, but we never got there because it was like, no, that doesn't work. There are patients, and it's a lot more efficient to take care of your own patient because you know what the problems are. So I get up in the morning. I think I'd probably start around 7, you know, ish. Depends on what's going on. You might have a conference, you might not, but otherwise I round on my patients in the hospital. Got to the office at 9. Now this was later on. I mean, in the early days, you guys would just die. I mean, you know this, but I mean, you know, but you know, in the early days, we only had office hours in the afternoon. You know, it's like we had all morning to see patients. We had a lot more inpatients. But later on, it was more like 7 to 9, and then went to the office, and I spent the rest of the day in the office 9, you know, to
6.
well 4:30. I mean, the patient schedule stopped at like 4:30, but to 5, the latest. I mean, the latest patient coming in was 4 something. A lot of paperwork to catch up on. It's possible to go back to the hospital. And I was on call every, you know, depends on how many people were rotating the call, 5, 6, you know.
There used to be him and then him and one other, and then him and 2 others.
Yeah, when I got my first partner, I thought I died and gone to heaven. I was on every other night then, instead of every night. I thought I had died and gone to heaven. You know, when you're out, I had every other night off. What a great deal. And, you know, but eventually it was, you know, that way. And then weekends, we rotated the weekends, of course. So, so when you were at weekend call, you know, you were there like a lot of the day because a lot of these patients were sick or taking admissions coming in. And the night call wasn't bad. I mean, to be honest with you, at night, the night call's not bad. The nurses handle most of the problems. I mean, it's rare that, I mean, if I had admission or a consult, I had to go in. And this is different from, you know, 20 years ago, 30 years ago, where it was a lot more labor intensive. And that's because oncology has changed. And a lot of our patients are now, we have many fewer inpatients than we did before because a lot of our work is outpatient now. You know, our
So you
therapies are less toxic. I mean,
you admitted your patients to Boone, right? To Boone County?
Right, correct, yeah.
And so there are no residents there. Did that make a difference in terms of, you know, how your life went?
Oh, yes.
Well, I guess so. I don't really know. I mean, it's hard to tell. I mean, it not having, I mean, I was only the 1 year in academic practice, so I don't remember, you know, but, you know, you'd be surprised. I mean, you know, the patients, they're your patients, you've been rounding on them. When the nurse calls you with a problem, it's usually easy to handle. I mean, you're directly dealing with the nurse who's dealing with the patient. So in one sense, there are many fewer layers to deal with. So it's a lot easier to get something done. I mean, the bad news is, you know, if you get admission or, you know, consult, you got to go in and do it yourself. I mean, sure. But.
So, you know, there are increasingly large numbers of 2-physician families, and you're obviously in a position to, you know, offer some insight into how managing roles and responsibilities and work-life balance. Do you have any thoughts about that, or how you went about divvying things up and so on?
See, well,
Well, yeah. I mean, I think that, you know, from my standpoint, I wish I had spent a lot more time at home. I mean, we built a house. I mean, one of the decisions we made years ago, this house we're in right now, I'm about 2 minutes from work, you know, 2 minutes from the hospital. And the reason we built this part of town was because of that. Because before that, we were living in the southern part of Columbia.
well,
And
10 minutes further.
10, 15 minutes further, I realized. But it was a point where I couldn't come home for dinner because it would be like 15, 20 minutes home, 15, 20 minutes back. And you know, just my day would become much longer. So one of the deals was I wanted to get home for dinner, so this way I could do it. But oftentimes I had to go back. I don't think that's. I don't think physicians today are going to really put up with that. I mean, that's one of the issues that are reality. I think that, you know, you've got kids to take care of, you've got family life. The question is, how do you take care of patients, and how do you take care of yourself at the same time? So I'm not at all saying that people should do what I did in that sense. I mean, I think that the issue here is still control in many ways. How much do you want to do? But on the other hand, I think you can't get into this mindset of just clocking in and clocking out. I think that's really a bad thing for your own, for your patients, but also for your own quality of life in terms of your professional life. I mean, I think you still got to be invested in your patients, even if you control your time.
Are there any things that you think you should have known or noticed before you took the first job, or that you would warn people to look for?
I think you need to sort of get into the depth a little bit with the people that are there when you're interviewing, to try to figure out the environment, you know, to try to figure out their happiness, to try to figure out the personalities. Obviously, people change, and so I mean, like, people come and go, so people don't change. Those people don't change. I mean, people come and go. And you know, it's a difficult problem. I mean, because you're trying to ferret out something that they don't really want to tell you. You know, people that are there don't want to tell you. I mean, one time we were interviewing for fellowships. We did our residencies at Missouri, if you remember, and then we went to do fellowship. And the we were interviewing for fellowships, and we went to Ohio State, very, very well-regarded program. And we got there, and we were trying to interview. We had sort of arranged to talk to some of the fellows, but they were all sort of being kept in captivity or something. And so they said they sent us over for a while to talk to some of the wives while they're waiting for the fellows. This was back when most of them were men and women. So talk to the wives, and one of the wives said, "Oh," she said, "really, it's not bad." She says, once you get over that first year of depression, it's really not too bad." I'm going like,
really? And that was just an accepted part of it.
Like that offhand comment.
And we thought, oh.
And you know, the head of the division was this really rigid, militaristic guy. You know that we just sort of packed up and left and went to do.
Yeah.
Which, by the way, despite Duke's reputation in HEMONC, was very easygoing, and well-functioning.
Wendell Ross is
friendly
the sweetest
place.
person in the universe.
You know, are you going to have supportive faculty members or not? You know, supportive colleagues or not? You know, and trying to ferret that out is something that's really important. And I don't know of any tricks, Dan, to do that. I mean, it's like, you've got to talk to people. You got to get them off guard a little bit and say, you know, what don't you like most about it? Or what's the thing that bothers you, that bugs you the most? You might.
Or what would you change? Or can you change it? Yeah.
Yeah. So, I mean, I think that's the only thing you can do. I mean, you're going to become like any other job or profession or anything else. You're going to become like the people who were there. Or if you're not, you're going to be unhappy. I mean, those are that's what happens. I tell the students this too, you know, when you go into a specialty, look around, because those are the people you're going to be. I mean, like, if you're going into urology, that's what you're going to be. You're going into orthopedic surgery, you're going to end up being like those people. And you've got to feel comfortable with that. And if you don't, then you're in the wrong thing. You know, that's the way I see it.